Great, thank you so much, Bridget. And thank you for the opportunity to present Section GG today. Appreciate everybody's attendance, both in person and online. So to get started, as with all of the presentations, we have a list of acronyms at the beginning of the presentations. There's also information in your packet with the listing of all of the acronyms across all the presentations. In terms of learning objectives, so there's 3 goals for this actual presentation. And we're going to actually go till about 10 o'clock, take a break, and then we've got about another 45 minutes of content with some examples after the break. So again, the learning objectives include my hope is that after this presentation, you'll be able to demonstrate an understanding of the standardized items in Section GG, functional abilities and goals. You'll be able to describe the intent, coding instructions and definitions of the new Section GG items, and you'll also have some opportunities to apply coding instructions to accurately code practice scenarios, and then again the case study this afternoon. So just to give you an overview of the types of items included in Section GG, there are several questions related to the person's prior functioning. And so there's a GG 0110, which relates to prior functioning with everyday activities, things like self-care, mobility. There's also a list of mobility devices that we ask you to check whether the person was using a device prior to the current illness, exacerbation, or injury. And those are completed only at the start of care and resumption of care, those 2 prior functioning. The main set of items in Section GG relate to the self-care and mobility, that is the GG 0130 and GG 0170 items. And those are completed at the start of care, the resumption of care, follow-up, and discharge from agency, not to an inpatient facility. So I know many of you may be wondering why these items are being added to the OASIS. So CMS is currently aligning quality measurement across the post-acute care assessments to meet the provisions of the IMPACT Act. The IMPACT Act is Improving Medicare Post-Acute Care Transformation Act, which was passed in 2014. And part of this is the move towards standardized assessment data, which facilitates cross-setting data collection, quality measurement, outcome comparisons, as well as interoperability data exchange. I know one of the topics yesterday brought up was the communication across different care settings. So Section GG will be added to the OASIS for quality measurement and alignment with other post-acute care settings, including inpatient rehab facilities, skilled nursing facilities, and long-term care hospitals. So as Bridget mentioned earlier, the Section GG items were added to the data sets in these 3 settings back in 2016, and so there's been a lot of experience with these items from those settings. And here's a graphic just showing snapshots from each of the different care settings and their respective assessment instruments. So obviously home health is there with the OASIS. The SNF uses the MDS, the IRFs use the IRF-PI, and the LTACs use the LTAC care data set. But as I mentioned before, the items are the same when they're on those data sets. So eating, for example, is defined the same across all of those data sets. So we did want to highlight that there are differences, obviously, between the Section GG items and the M items that you have been completing. So it's important to understand the tasks that are included in each of the activities. So I'll be going over that today, going through the definitions and kind of highlighting some of the important issues in terms of the definitions and how to code the items. And obviously the rating scale is a different rating scale than the Section M items. So one question too we've heard is, how will this data be used? So the section GG data elements, some of them are used to calculate the cross-setting quality process measure, which is called application of the percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that includes function. And if you're wondering why long-term care hospital is part of the title, that's because this is a quality measure that has been endorsed by the National Quality Forum for the long-term care hospital setting, and CMS adapted the quality measure for use for the purpose of the IMPACT Act and applicable to all post-acute care settings. So basically, the application part of the title means that it's modified. So basically, this particular quality measure, as I said, was specified in order to be cross-setting, including for home health, and it reports the percent of patients with a SOC, ROC, and a discharge functional assessment and a treatment goal that addresses function. I'll be telling you a little bit more about the quality measure after the break, so more to come on this. So to begin with the actual training, so we're going to start off with the items that focus on the person's status prior to the current illness, exacerbation, or injury. And so the first one is GG0110, called prior functioning everyday activities. And the intent of these particular items relate to understanding the patient's usual ability with everyday activities, again, prior to the current event that triggered the need to receive care in home care, or perhaps the person was admitted to acute care and then came to receive care in home care, and so this would be the time prior to the acute care stay. So as I mentioned, this is completed only at SOC and ROC because the information, again, refers to the time prior to the current illness, exacerbation, or injury. As you can see from the screenshot that's taken exactly from your data set, the coding options are on the left side. We'll be going over those. And then there are 4 areas that we'll be talking about related to prior functioning, and that those areas are self-care, indoor mobility, specifically ambulation, stairs, and functional cognition. So in the area of self-care, that would encompass assistance that the person may have needed with activities such as bathing, dressing, using the toilet, or eating. And as you can see from the coding, you'd be indicating whether the person was independent with that or needed some help or was dependent. The next area for prior functioning relates to indoor mobility, specifically ambulation. And for this, you would be coding based on the person's need for assistance to walk in between rooms, so walking room to room. And this would be regardless of whether they use a device or not. So it's just, did the person actually need assistance from another person, a helper? The next area is stairs, and this relates to the person's need for assistance to manage either indoor or external stairs. Again, the person could be using a device or not, and the focus is on whether helper assistance was actually needed. And then finally, functional cognition, which relates to the patient's need for assistance with planning regular activities, tasks such as going out shopping, remembering to take medication, things like that. So one of the main ways that this information can be collected is by asking the patient or family member if they're able to provide that information. If you have access to medical records from acute care, that information may also be in that particular record. I know yesterday I heard that's not always happening. So it may be that the main source of information is the patient and or family. So in terms of the codes, I've highlighted them a little bit before. I want to go in depth now. So for each of those areas that I just mentioned, those 4 areas, you would be coding that the person is either independent, which would be code 3, and that means that the person completed the activities by him or herself, and again, regardless of assistive device use, but no assistance from another person, a helper, was required. Code 2 would be used if the person was able to perform the activity but needed partial assistance from another person to complete the activities. Code 1 would be used if the person was not able to take care of themselves with that activity, and so somebody helped do that activity for the person. Certainly we understand you may not always be able to get the information. As I said, if you don't have access to a medical record, perhaps the patient is not able to remember or there's not a caregiver. And so if that is the situation you find yourself in, there is a code 8 unknown to indicate that you were not able to get the information. And then code 9 is available if for some circumstance an activity was not applicable. So an example of this might be for the mobility item where we talked about ambulation. Perhaps this is somebody who has a longstanding chronic illness and has been using a wheelchair for a long time, and so they're not ambulatory. So you would code 9 not applicable in that example. So again, coding tip, if you're not able to get the information, you've made an attempt to interview the patient or family or access a medical record, and if that information is not available, you can code unknown. The second topic area related to prior functioning is prior device use, and that's GGO 110. And so the intent of this item is to document whether the person used devices or aids immediately prior to the current illness, exacerbation, or injury. And it provides information that is helpful to determine the patient's potential functional abilities and discharge and goals. So this is completed similar to the prior item, just at Sock Rock. And as you can see, the items that you are indicating whether the person used prior to the current illness, exacerbation, injury are manual wheelchair, motorized wheelchair and or scooter, a mechanical lift, walker, an orthopedic or a prosthetic device. And if none of those apply, there's an option to check none of the above. So again, similar to the prior item, this information can be obtained by interviewing the patient or reviewing the person's medical record. Again, the coding instructions, you would check all that apply. If the person perhaps uses a mechanical lift and then also has a motorized scooter, you would check B and C in that instance. You can check multiple items. And if none of those mobility devices apply, you would just check a Z. I know one of the questions that we have gotten from the other settings is what if the person uses a cane, for example? In this instance, it's not on the list, and so you'd say none of the above. So we certainly recognize that somebody may be using another type of device, either a mobility or something for self-care. So this is not a comprehensive list. There have been lots of questions previously also about mechanical lift, and so we wanted to share with you a bit more information about that. So mechanical lift, which is item C, would refer to any device that a patient or caregiver requires for lifting or supporting the patient's body weight. And so examples of a mechanical lift could include a stair lift, a Hoyer lift, or a bathtub lift. We also have questions, actually going back to when we started with the IRF, about what are walkers, what would be included. Any type of walker can be included for here. So that would be a pickup walker, a hemi walker, a rolling walker, or a platform walker. Any type of walker is fine. All right, so now moving into the GGO 130 self-care and GGO 170 mobility items. So these particular items, again, look at assessing the patient, the patient's performance in terms of self-care and mobility activities at the time of the start of care or resumption of care, as well as discharge. So just in terms of how this relates to time points, so Sock Rock, you would be completing the Sock Rock performance. Also on the Sock Rock, you would be documenting the patient's discharge goal in relation to any of the self-care or mobility activities. At follow-up, you would be reporting follow-up performance on a select group of items of self-care mobility. And then discharge from agency, not to an inpatient facility, you would be completing discharge performance. So in terms of the process for collecting the data, so any qualified licensed clinician may assess the patient's performance based on direct observation, which is the preferred mode of getting this information. But in the event that you may have other resources, you may use those resources, including reports from the patient. So you may ask the patient to describe what their usual way of, let's say, going to the bathroom is, or perhaps when they eat. You might be asking them questions about that, including some probing questions. You may also be asking other clinicians for input, other direct care staff, or perhaps family or carers that live with or work closely with the patient. So CMS certainly does invite a multidisciplinary approach to patient assessment. So when the assessment is performed, the patient should be able to perform the activity as independently as possible so that you can get an accurate picture of the person's abilities. So as long as they're safe, allow the person to be as independent as possible. If assistance from a helper is required because the patient's performance is unsafe or of poor quality, score according to the amount of assistance required. Activities may be completed with or without an assistive device, and the use of the assistive device does not increase or decrease the score in any way. You just score the patient based on the device that they typically use. For patients with cognitive impairments and limitations, these patients may need assistance, for example, maybe additional verbal cueing, or maybe you have to provide some touching contact guard assistance in order for them to perform the activity safely. And in that instance, you code based on the type and amount of assistance, even if the assistance is due to cognitive limitations that the patient is experiencing. Again, code based on the patient's need for assistance, again, regardless of why they need assistance, to perform the activity safely. So, for example, we have some examples here where somebody may be at risk for choking due to the rate of eating, so you may need to cue somebody to slow down eating, and so that would be definitely considered as assistance. Perhaps they're just putting up too much food in their mouth or need reminders to swallow, or maybe the person's at risk for falling and you have to provide some cues to them or provide steadying assistance. So that assistance would be reported. So if you look at the OASIS-D, you'll see this is what the self-care performance area looks like, and you see highlighted in yellow the performance column. The second column is where the discharge goals would be reported. These are the mobility items, so you can see that spans over 2 pages, and the first column again is performance and the second column is goals. You'll see in the area of mobility at the end, and that's on the second screenshot, that there are some gateway questions and follow-up questions about type of wheelchair, so we'll cover those when we get to those later today, but those are indented a little bit. So talking about the instructions a little bit more in detail, so a patient's functional status should be based on an assessment that occurs soon after the patient's sock rock. It should reflect the person's baseline status, and again should be based on observation as much as possible. When possible, the assessment should occur prior to the start of therapy or start before the person benefits from therapy in order to capture the person's true baseline assessment prior to interventions. Certainly therapy interventions can affect somebody's functional status, and so we're trying to get a baseline assessment at the time of admission. A patient's functional ability can also be impacted by the environment or situations that are encountered in the home. And so observing the patient in different locations and circumstances within the home is important for a comprehensive understanding of the patient's functional status. If the patient's status varies during the assessment timeframe, record the patient's usual ability to perform the activity. Do not record the patient's best performance or worst performance when there is variation. Instead, CMS is interested in the patient's usual performance. So the maximum number of, the assessment timeframe refers to the maximum number of days within which to complete the assessment. And then when we talk about usual ability, that refers again to the ability greater than 50% of the assessment time frame. So as I mentioned, goals are also available on the SOC-ROC, and again, that's in the second column for self-care as well as mobility. And in regard to the goals, so the patient's goals are coded using the 6-point rating scale. We'll be going over the rating scale shortly, but it's 2 digits, so either 01 through 06, or if depending on the patient's circumstance, it's possible that one of the activity not attempted codes might be applicable. And this is new guidance, I did want to highlight this. But it's possible to code a goal as 07, 09, 10, and 88. As I said before, this is new guidance. In fact, when these items were implemented in IRF, SNF, and LTAC, these codes, only the code 01 through 06 were allowed. And we've had a lot of feedback that people were interested in having available the activity not attempted codes, so those are possible to be coded. I will tell you in the training that we've done, people do ask for examples. We don't have a lot of good examples of patient refusal being a goal, but certainly it can happen. But we don't have, lots of examples, and we don't expect it to be used. But again, CMS was asked to have those available, and so those are options for you. So you can also use a dash for any remaining self-care or mobility goals that you don't report. And we'll talk about the goals in relation to the quality measure at the end of the presentation. Discharge goals may be coded the same as what the person's performance was at SOC-ROC. So for example, it's possible that somebody is admitted independent with eating, and the goal is to maintain that the person is independent. So that's certainly fine to have the same level at the time of SOC-ROC and that level as a goal. It's possible that the person may be maybe somebody's recovering from a hip replacement or a hip fracture, and so the person's mobility score, let's say, is a level 2, and the goal is to improve the person's mobility activities, and so the expectation is the person perhaps is going to be independent by the time home care is completed, and so the SOC-ROC score performance might be 02, and then the goal is to be 06. It's also possible, as you know, that somebody may have expected decline in function because of a chronic progressive condition. And so it's possible that in this instance that the score may be lower. For example, somebody who is expected to decline, you would see perhaps lower goals in some areas. If the SOC-ROC performance of an activity was coded using one of the activity not attempted codes, so for example, maybe at the time of admission, somebody maybe had some kind of severe swelling problem, and so they were not able to eat, but the expectation is that the person will be able to eat perhaps by discharge. They've got some great treatment that is working for them. And so it's possible that you may have a goal for them to be independent or perhaps just need moderate assistance. So any goal can be coded for any item. Okay. In terms of goals, we do get questions on the help desks about how to set goals. And so this is a very individualized process, but certainly licensed clinicians can establish goals at the time of SOC-ROC, and it can be taking into account the patient's prior medical condition, the person's performance at the time of the admission, self-care and mobility status, discussions with the patient and family. Ideally, obviously, goals that are co-created with the patient and family are the ideal. Professional judgment and experience obviously can play an important role. The profession's practice standards, so if you're a therapist or a nurse, expected treatments, if the person is expected to get intensive therapy, perhaps the goals might be more focused on those areas. Patient motivation certainly can make a difference, anticipated number of treatments, length of stay, as well as the discharge plan. So goals should be established as part of the patient's care plan. In the situation when you're doing a follow-up performance assessment, there are actually 3 self-care items only on that assessment that would be completed, and those are eating, oral hygiene, and toileting hygiene. And then for follow-up performance in the area of mobility, the areas that are covered include several of the bed mobility items, some of the walking items, steps, and one of the wheelchair items. Clinicians should code the patient's performance at follow-up based on an assessment that occurs within the assessment timeframe for follow-up. In terms of the discharge performance, so the self-care activities that are completed at the time of discharge include the 7 self-care activities that were completed at Sock Rock, and those include eating, oral hygiene, toileting hygiene, shower-based self, upper body dressing, lower body dressing, and putting on and removing footwear. In the area of mobility, similar to admissions or Sock Rock, the discharge performance includes the bed mobility items, transfer items, several walking items, both regular walking on even surfaces as well as uneven surfaces, steps, picking up an object, and the wheelchair items. In terms of the particular discharge performance, so the discharge time frame is the last 5 days of care, and this includes the day of discharge, the discharge visit, and the 4 preceding calendar days. So code the patient's functional status based on the assessment that occurs as close to discharge as possible. Again, for the span of time for data collection, for most OASIS items, this is the day of the assessment. For other items, item wording or related guidance will specify the time period under consideration, such as since the most recent Sock Rock. So now we're going to spend a little bit of time talking about the rating scale that's used for the self-care and mobility activities. So basically, a higher score indicates more independence, and at level 6, we start off with independent. At level 5, that is setup or cleanup assistance, and think of this as the level of care that a helper, whether it's a family member or perhaps somebody else, who is actually leaving something in place for the patient, and then the patient can use that device or whatever's been set up a bit of time after that, so the person who is actually providing the setup or cleanup assistance doesn't have to be with the patient when that exactly happens. So for example, if you have a carer who needs to go off to work and the person needs a wheelchair put in place beside their bed so they can get in and out of bed, the person who needs to go off to work can certainly put the wheelchair there in place at 6 o'clock in the morning when they leave, and then the person can get out of bed at 8 o'clock 2 hours later, or 5 minutes later. And so prior time is a really helpful thing I find to think about in terms of what type of assistance is set up or cleanup assistance. Level 4 refers to supervision or touching assistance. Level 3 refers to partial or moderate assistance. Level 2 is substantial, maximal assistance, and level 1 is dependent. In the event that the patient is not able to perform a daily activity that's included on the OASIS-D in section GG, CMS would like to know why. And so there are various reasons why an activity may not occur, and those are listed here. So you would code 07 if the patient refused to perform an activity, code 9 if an activity was not applicable. And we'll be going through the definitions of these in a little bit more time, but basically not applicable means that the person has not been doing this activity for some time. Code 10 refers to not attempted due to environmental limitations, we have some examples of those as we go through the slides. Code 88, not attempted due to medical condition or safety concern, is one of the main reasons that is coded when an activity doesn't occur. It's often because of a medical condition or safety concern. So in order to help you kind of understand how the scale works and talk through some examples, I wanted to go through a decision tree to help you kind of understand how each level works. And when we go through the coding examples together, I'll remind you about this and kind of try and help you as we think through how to code the examples, relate back to this, and how to think it through. So my goal is to introduce this to you now and then reinforce it later. So when you're coding a particular item or an activity, you would think about, first of all, does the patient complete the activity by him or herself with no assistance? And when I say no assistance, that refers to no physical assistance, no verbal, nonverbal cueing, no setup, and no cleanup. If the answer is yes, that the person is able to complete the activity without any assistance from a helper, you would code 6, independent. If the answer is no, you would then move to the next question, which is, does the patient need only setup or cleanup assistance from one helper? If the answer there is yes, you would code 5, setup, cleanup assistance, and I said that example is, basically providing a device for the person to put in place so they can transfer out of bed in the morning, or maybe the person needs a reacher in order to pick up an object, and the helper provides that reacher to the person. That would be another example of setup. So if the patient needs more than setup or cleanup assistance, then the answer is no, and you would go to the next question, which is, does the patient need only verbal or nonverbal cueing, or only touching, steadying contact guard assistance from one helper? If the answer is yes, you would code 4, supervision or touching assistance. If the answer is no, you would then move to the next question, which asks, does the patient need physical assistance, for example, lifting or trunk support, with the helper providing less than half of the effort? If the answer is yes to that, you would code 03. If the answer is no, because the person needs even more assistance, then you would ask the next question, which is basically, does the patient need physical assistance, for example, lifting or trunk support from one helper, with the helper providing more than half of the effort? In that instance, you would code 02. If the answer is no, you would ask the last question, which is, does the helper provide all of the effort, or is the assistance of 2 or more helpers required to complete the activity? If either one of the answers there is yes, you would code 01. So just as an example of how we develop the decision tree, so if the assistance of 2 or more helpers is needed, you can see you're going to actually go all the way down to level 1 automatically, because throughout the questions we talked about one helper providing assistance, one helper. So once you need 2 or more helpers, you're always going to be coding level 1. So as I mentioned before, the activity not attempted codes are available, and Patient refusal is pretty straightforward. I think some of the questions that have come up, which have been good, we've had questions where somebody said, well, what if the person says, I'm not going to do that because I'm having pain? So it would be the clinician's judgment whether you would say it's a medical condition or safety concern. If the person truly having pain, it's legitimate that they may not want to perform an activity, and so you may be coding 88 activity not attempted due to medical condition or safety concern. But you may also, depending on the circumstance, consider it a refusal. 09, so 09, which is called not applicable, refers to the situation where the person does not perform the activity at the time of the assessment, and the person didn't do the activity prior to the current illness, exacerbation, or injury. And I think the most common example that we've had on help desk relates to the situation where somebody perhaps is not walking, and so perhaps somebody has used a wheelchair for many years due to a chronic illness, or perhaps a medical condition, and so the person was not walking prior to the current illness, exacerbation, or injury, so you could code 09 for that individual. Code 10 is a new code for actually all of the settings in 2018 and 2019 for you, and this is not attempted due to environmental limitations. Probably this won't be coded for many of the self-care activities, but certainly something like car transfer is where we would expect to see this used, or walking on uneven surfaces is another activity where perhaps, it's, you live in North Dakota and it's really cold at the time, and you're not going to take the person outside maybe to walk on uneven surfaces, and there's nothing in the person's home to test them with. And so weather constraints certainly is part of environmental limitations. Lack of equipment, for example, not having a car to be able to transfer into. But I wouldn't expect, for example, code 10 to be used for eating. So again, probably not going to be used that much, but an important code, I think. And then, as I mentioned, code 88, we expect to use most of the time. This is what we see most commonly in most of the settings, and it refers to basically the person having a medical condition or a safety concern. So I did want to mention DASH. So the use of the DASH is not expected to be done commonly across any of the items, including GG. It indicates that no information is available. So I just wanted to be sure that if an activity doesn't occur, that you code the activity not attempted codes. Don't default to a dash, because CMS does look at that information, and we would like to know why the person was not able to perform the activity. So again, the activity not attempted codes are appropriate. Additional coding tips want to follow through on. So use of the assistive device or adaptive equipment does not increase or decrease somebody's score. If the person uses a cane or a walker, code based on the type and amount of assistance from a helper that's being provided to the patient, regardless of the device use. If the only help a patient needs to complete an activity is to retrieve an assistive device, such as a cane for walking or a tub bench for bathing that they need, that would be setup or cleanup assistance. If 2 or more helpers are needed to complete the activity, code dependent. So I mentioned that in relation to the decision tree earlier. Okay, so now we have an opportunity for a knowledge check. So if you don't mind pulling out your phones and pulling up Slido. So the first question we have for knowledge check is, what is the preferred method for assessing the patient's self-care or mobility performance? The options that you can select are A, patient report, B, family report, C, direct observation, D, report from other care staff. So again, the preferred method, so the main method. So it looks like 99% of you have coded C, and I do agree with that. So we'll move on. Oh, still some more people. Okay, so I agree, the correct response, there we go, direct observation, perfect. Okay, so as I mentioned before, a qualified licensed clinician may assess a patient's performance based on observation, which is the preferred method, but certainly the other sources that were mentioned are also available. So we have another knowledge check. Which example below best demonstrates allowing the patient to function as independently as possible? So the options that you can choose from are A, feeding a patient who can feed himself in order to expedite mealtime, allowing the patient to brush her teeth as much as possible, assisting only if she becomes fatigued. C, providing the assistance with the bedside commode, the patient with bedside commode when he is capable of walking to the bathroom with assistance. And D, all of the above. So it looks like the votes are still coming in. There seems to be an overwhelming favorite. Okay, I do agree with the direction. B would be correct. So again, part of the assessments, it's important to allow the person to be as independent as possible in order to get a true baseline assessment of the person's ability. And so you were correct in the example that you picked. Okay, another one. Since Mrs. W uses a rolling walker, she cannot be considered independent for section GG walking items. Would you consider that a true statement or a false statement? Okay. All right, the votes are still coming in. Okay. All right, that would be false. Certainly, a person can be independent and use a device. Use of a device can occur at any scoring level. Again, the scoring level varies depending on the type and amount of human assistance being provided. Okay, so we're going to talk now about each of the activities or the items. We're going to start obviously with self-care, section GG 0130. So we're going to start off with eating. So eating is defined in section GG as the ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid once the meal is placed before the patient. So meal preparation is not included, so this is truly just the task of eating, and includes both solid foods as well as liquids. One thing I would like to highlight is that this does refer to eating by mouth. So if somebody does not eat by mouth, perhaps somebody has a swallowing problem, you would indicate that the activity did not occur, and perhaps it's a medical condition, a swallowing problem, perhaps maybe after a stroke, and so you would code 88, activity not attempted in that instance. So again, it is about eating by mouth. So we actually have had many questions over the years in particular about this item, so just wanted to give you kind of different scenarios to help solidify this issue. So if a patient uses either a G-tube or TPN, the assistance with the tube feeding or TPN is actually not considered in the eating item. Again, it just relates to bringing food to the mouth. If the patient does not eat or drink by mouth and relies solely on nutrition and liquids through tube feedings or total parenteral nutrition due to a recent onset medical condition, you would code 88, not attempted due to medical condition or safety concern. If the patient does not eat or drink by mouth at the time of the assessment, and the person perhaps had a long-standing swallowing problem and has had a G-tube for many years, the appropriate code in that situation would be 09, not applicable. And again, 09 refers to the person doesn't perform the activity now and did not perform it prior to the current illness, exacerbation, or injury. And then the last possibility that we have is if the person does eat or drink by mouth and also has either a G-tube perhaps or TPN, then you would code based on the amount of assistance with eating by mouth. So bottom line, if the person does eat by mouth, you can code it. If the person doesn't eat by mouth, you'd be coding one of the activity not attempted codes. So we do have another example here to go through together, if you can pull out your phones. And I do want to highlight that these examples are in your packet, so if you did want to look at these, you can look at them on the slide, or you can look at it in your packet, and in case you need a little bit more time. So we have an example here for eating. Mr. R is unable to eat or drink by mouth since he had a stroke 1 week ago. So the important piece of information is 1 week ago. He received nutrition and hydration through a G-tube, which is administered by a helper. So how would you code eating for Mr. R? You could code A, code 1, dependent, 2, substantial assistance, 9, not applicable, 88, not attempted due to medical condition or safety concern. Looks like we've got about 80 people who have coded so far. There seems to be a favorite. Okay, great. So I do agree, 88, medical condition or safety concern. It was a recent onset, and so that's why it's not a 9. Okay, the next activity is oral hygiene. So this includes the ability to use utensil items to clean teeth, and if the person uses dentures, it would be the ability to remove and replace the dentures to and from the mouth, and manage equipment for soaking and rinsing. If the patient does not perform oral hygiene during the home visit, determine the patient's abilities based on the patient's performance of similar activities or simulation during the assessment, or on the patient or caregiver report. We do have a practice scenario here. This happens to be an observation. So in this instance, the helper provides steadying assistance as Mr. S to Mr. S as he walks to the bathroom. And let me just tell you that's a distractor. So for all of the self-care activities, we're really focused on the person being able to perform the act of eating or brushing their teeth, toileting hygiene is once they're in the bathroom. The walking to and from will get coded in the mobility section. So we've given you a bit of distractor information. You can ignore that now. The helper applies toothpaste onto Mr. S's toothbrush. Mr. S then brushes his teeth at the sink in the bathroom without physical assistance or supervision. Once Mr. S is done brushing his teeth and washing his hands and face, the helper returns and provides steadying assistance to the patient as the patient walks back to his bed. So let's just talk through this with the decision tree. So first of all, does the patient need assistance from somebody to perform the activity of oral hygiene? And somebody is actually putting toothpaste on the person's toothbrush, and so there is assistance. So the person's not independent. So the next question after in the decision tree is whether only setup or cleanup assistance was provided. In this case, putting toothpaste on the toothbrush is setup assistance, and so we have to think through whether additional assistance is provided. Again, we ignore walking to the bathroom. We can ignore walking from the bathroom. It says that there was no physical assistance or supervision being provided. He's washing hands and face, but that's not included in the definition. And so basically, I think I've kind of helped you apply the decision tree. And by the way, the setup, cleanup, here again, applying toothpaste to a toothbrush, that can happen at 6 o'clock in the morning, and somebody can brush their teeth at 8 o'clock in the morning. So again, that prior time that can happen with setup or cleanup assistance is applicable here. Okay, so how would you code this one? Options are 05, setup cleanup assistance, 04, supervision touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance. Okay, it looks like quite a few people have voted. We're up to 93 people. I'll give a little bit of time for online folks to enter. Okay, and I do agree, set up cleanup assistance for that. And again, the rationale is that it's just assistance putting on the toothpaste on the toothbrush, and the walking is not a consideration. Okay, moving on to toileting hygiene now. So this refers to the ability to maintain perineal hygiene, adjusting clothing before and after either voiding or having a bowel movement, and if managing an ostomy would include wiping the opening but not managing the equipment. So basically, there's a separate item that's going to relate to toilet transfer, getting on and off the toilet, but toileting hygiene basically refers to when the person is in the bathroom and they are, or maybe using a urinal, and the person will need to manage clothing, and they will then do what they need to do. They will do a cleanse, and they will, pull their pants back up. So it's really pulling the pants down, cleansing, and pulling the pants back up. There's kind of 3 tasks related to toileting hygiene. So again, you'll be paying attention to assistance needed during either pulling the pants down, or maybe some cleansing, or maybe pulling the pants back up. Let me just give another little bit about this. So if somebody maybe is a bit unsteady, and so a helper has to provide steadying assistance while the person, is pulling their pants back up, that would be steadying assistance. If somebody, maybe is a bit unsteady, but you don't actually have to touch them, but you feel like you need to be there to supervise, that's, also level 4 supervision. If you're starting to actually provide trunk support, or perhaps actually maybe the pants fall down all the way to the floor and the person is not able to pick those pants up easily without losing balance, so maybe there's assistance, so that's where you start getting level 3 and lower. Okay, the next activity is shower, bathe, self. So this is defined as the ability to bathe self, and it does include washing, rinsing, and drying. It does not include washing the back or washing hair, and again does not include transferring into and out of a tub. It is truly just washing the body, washing, rinsing, and drying the body. The next 3 activities relate to dressing. So it's split up for upper body dressing, which is basically the ability to dress and undress above the waist, including fasteners, code based on whatever the person wears. And so, a woman may be wearing, let's say, a bra and an undershirt and a button-down shirt, or maybe just a t-shirt. Whatever the person's wearing is what you would assess them on. For lower body dressing, that relates to the ability to dress and undress below the waist, and it includes fasteners, for example, if pants are being worn, and there is a separate item for footwear, so basically lower body dressing kind of ends around the ankle. And then finally, putting on and removing footwear, which can be challenging for some people. And so this is the ability to put on and take off socks and shoes or other footwear that are appropriate for safe mobility, including fasteners if applicable. We have had questions on help desk over the years about what is footwear. So you would be using your clinical judgment in terms of what is safe footwear. Okay, next we're going to move on to the mobility items, and again we'll be going through the definitions and then trying to go through some examples together. And so just as a reminder, the items, this is what they look like on the actual OASIS-D, the first column being the performance that's coded at the time of SOC Rock, and then the discharge goal is the second column. And then these are their remaining items on the second page. So the first activity, we're starting off with the easier items. So we start off with bed mobility activities. So the first one relates to rolling left and right, the ability to roll from lying on the back to the left and right side, and then returning to lying on the back of the bed. So we do have an example, if you can pull out your phones. So at SOC, the physical therapist helps Mr. R turn onto his right side by instructing him to bend his left leg and roll onto his left side. He then instructs him how to position his limbs to return to lying on his back, and then repeat a similar process to roll on his left side and then return to lying on his back. Mr. R completes the activity without physical assistance from the helper. Mr. R was moving about in bed without difficulty prior to the hospitalization. The physical therapist expects Mr. R will roll left and right by himself by discharge. So let's walk through the decision tree in terms of the SOC performance score. So the assistance from the helper, it looks like the helper, in this case it's physical therapist, is providing instructions, so that's verbal. So the first question is a helper needed? And the answer basically is yes. And so, I'm sorry, the first question is whether the person did it by themselves. So the answer is no, the helper was needed. And so then we would say, does the person just need setup or cleanup assistance from one helper? And the answer is no, it's more help than that. Somebody is actually staying with the person and actually providing verbal cueing during the time that this bed mobility activity is occurring. So the next question is it just verbal, nonverbal cueing, or touching, steadying assistance? And it does appear that that's a level of assistance. Does that seem right to you? Okay. All right. So, so that will be scoring performance. And then also we are provided with information about goal. This is kind of easy. The therapist expects Mr. R will roll left and right by himself by discharge. So I'll let you code that one on your own. So first of all, performance. So in terms of the instructions that were being provided to help lift his legs so that he can easily turn in bed, how would you code that? The options are code 5, setup cleanup assistance, code 4, supervision or touching assistance, code 9, not applicable, code 88, not attempted due to medical condition or safety concern. So I will let you vote. Let's see, I don't see them coming up here, but there we go. Okay, so you can code 5, 4, 9, or 88. Looks like the votes are coming in. Okay, great. All right, so I do agree with majority of you coded 04, touching supervision assistance, which includes that verbal cueing instruction. How about the goal? How would you code that? This was, I think, easy. He's expected to do that by himself. How would you code that? 6, 5, 7, or 9? Okay, great. Looks like the codes are coming in. All right, terrific, independent, exactly. And again, the rationale is that it was just verbal assistance being provided, and so that's why he's coded 4, supervision, touching assistance. Somebody's there the entire time the activity occurs, but it's not physical lifting assistance that's being provided, and then the goal is for independence. Okay, the next activity in the area of mobility is the ability to move from sitting on the side of the bed to lying flat on the bed. And so we do have another scenario here. So we have an example. Mr. A suffered multiple vertebral fractures due to a fall off a ladder. At SOC, he requires assistance from a therapist to get from a sitting position to lying flat on the bed because of significant pain in his lower back. The therapist supports his trunk and lifts both legs to assist Mr. A from sitting on the side of the bed to lying flat on the bed. Mr. A assists himself a small amount by raising one leg onto the bed and then bending both knees while transitioning into a lying position. So as we walk through, so this one's a little bit trickier, there's more things going on. So let's walk through the decision tree together. So First question is, can he do it by himself? No. So then is it just set up supervision or set up from a helper, one helper? No, it's more than that. So then does the helper provide less than half of the effort? No, I think it's a bit more than that. The patient, in this case, is definitely doing something, but the helper is doing more than half of the effort. In order to be coded dependent, that basically means that the person, the patient is not helping with the activity. So I think, it's in between the 3 and the 1, basically. So I will let you put the code in that you think is the best one. So the options are 5 setup cleanup assistance, 4 supervision touching assistance, 3 partial moderate assistance, 2 substantial maximal assistance. So again, level 2, the helper is performing more than half of the effort. Level 3, the patient is performing more than half of the effort. Okay, looks like most of you got that right. The correct code is level 2. Again, there was definitely a lot of effort that the helper was doing by lifting both legs and helping the person with trunk support as he was kind of lowering down. Patient definitely was doing a little bit of the effort, and so that's why it's a 2 and not a 1. Okay, and there's the rationale. Okay, the next activity is an item that you have been coding for some time. This is lying to sitting on the side of the bed, and it refers to the ability to move from lying on the back to sitting on the side of the bed with feet flat on the floor and with no back support. We have had questions, and so we have some coding tips here for you. If a patient's feet do not touch the floor upon lying to sitting, the clinician can determine if the bed height adjustment can be made, or if a footstool is required to accommodate foot placement on the floor or footstool. Back support refers to an object or person providing support for the patient's back. If at any time during the assessment the patient is unable to lie flat due to medical conditions or restrictions, but could perform this activity prior to the current illness, exacerbation, or injury, you would just code that 88, not attempted due to medical condition or safety concerns. If at the time of the assessment, the patient is unable to lie flat and could not lie flat prior to the current illness, exacerbation, or injury, you would code 09. So again, that's just reinforcing those 2 codes and how they're different. We have had many questions about what exactly is lying flat and, at what point is lying flat not happening. And so you would actually use your clinical judgment to determine if the person is lying flat. I think, for example, rolling left to right, at a certain point, it would be hard to ask somebody to do that and to assess it. And so, certainly that can be coded 88, activity not attempted due to medical condition or safety concern, if that's this instance. If the person just maybe has, due to some digestive issues, just have to have the head of the butt up slightly, perhaps you can assess some of these activities, but you would be making that determination. The next bed mobility activity relates to sit to stand, and this refers to the ability to come to a standing position from sitting in a chair, wheelchair, or on the side of the bed. If the only help the patient needs to complete the sit to stand activity is for a helper to retrieve an assistive device or adaptive equipment such as a walker or ankle foot orthosis, then the code would be 05 setup or cleanup assistance. So for example, in this instance, maybe the person has their walker in another location, and so somebody has to put the walker there so the person can stand up holding on to the walker, and so they use that for support. We do have another coding scenario. So in this instance, we have Mr. B. So Mr. B is being admitted for home care for pressure ulcer care. He has had complete tetraplegia, so he's got a spinal cord injury from an injury 1 year ago and has been unable to bear weight in standing since the injury. At SOC, using a patient lift that does not require him to come to a standing position, he is transferred from his bed into a wheelchair with assistance. So in this case, we're coding the sit to stand activity. So this gentleman is transferring, but he does not go from a sit to a standing position. And so you would be coding sit to stand in this particular example. And how would you code that if somebody is basically transferring him with a lift and he does not get to a standing position because he has again, a spinal cord injury and is unable to bear weight on his feet. So the options are code 2, code 1, 9, and 88. Okay, so we do have a bit of diversity here. I see a few more responses coming in. Okay. And the correct response is 09. I think most people did get that. And just to explain, so in this case, he is transferring. So again, the transfer item can be coded, but because he does not come to a standing position, the activity of sit to stand is not able to be assessed basically for this gentleman. And so because he had the long-standing spinal cord injury, it's not a new onset, and so it becomes 09, not applicable as opposed to the 88. If it had been a recent onset condition, it could have been coded 88. Okay, the next activity is the chair bed to chair transfer, and this is the ability to transfer to and from a bed to a chair or wheelchair. Just some coding tips based on help desk questions that have come in over the years. Sit to lying and lying to sit are not assessed as part of this activity because they're coded separately. If a mechanical lift is used to assist to transfer the patient from the chair or during a bed to chair transfer, and 2 helpers are needed with the mechanical lift transfer, then code 01 dependent, even if the patient assists with any part of bed chair transfer. So as I said previously when we were talking about decision trees, when the assistance of 2 or more helpers are required, it's always going to be coded 1. If only 1 helper is needed and the patient does participate and help, the person can certainly get credit for that and be coded 02. But when you have 2 or more helpers, it's always going to be a level 1, even if the person is helping a little bit with the activity. And again, as you can imagine, obviously the assistance of 2 helpers is significant. And so that's why that kind of becomes the key. Okay, we do have another coding example. Here, again, this is the bed chair transfer item that we're coding. Mr. L has had a stroke and uses a wheelchair for mobility. When Mr. L gets out of bed at SOC, the therapist moves the wheelchair into the correct position and locks the brakes so that Mr. L can transfer into the wheelchair safely. Mr. L transfers into the wheelchair by himself without the need for supervision or assistance during the transfer. The family reports that Mr. L does transfer safely, without the need for supervision once the wheelchair is placed and locked. The nurse does not expect Mr. L's mobility status to change by discharge. So we're going to code performance as well as goal here. And so in terms of current performance, it says that he can transfer safely. The wheelchair, the therapist moves the wheelchair in the correct position and locks the brakes, so that's setup assistance so that he can transfer, and it says he does not need supervision or assistance. So if we go through the decision tree, person's not doing it by themselves. And then the next question is whether it's just supervision or setup assistance. What do you think? Okay. All right. And then in terms of goals, it says that it's not expected to change. Nurse does not expect Mr. L's mobility status to change by discharge. So, all right, so if you can enter your responses into Slido, the options are 05, set up cleanup assistance, 04, supervision or touching assistance, 09, not applicable, 88, not attempted due to medical condition or safety concerns. Looks like we've got about 120 people who've submitted, and most of you are coding 05. I do agree with that. And then in terms of the goal, it said it was going to remain the same. So what do you think? Great. It'd be nice if he could be independent, but in this instance it said the same, so that would be a 5. Okay. All right, and again, this is the rationale. So the helper must provide setup assistance only. Once setup is provided, he does not need any additional assistance. Moving on to the toilet transfer item. So this refers basically to getting on and off the toilet or commode. So if somebody has a bedside commode, they can be assessed on that. If they go to the bathroom, they can be assessed on that. We're not worried about how they get to and from the bathroom. It's basically just getting on and off the toilet. Remember, we do have the separate activity of toileting hygiene, and obviously, you know, when somebody goes to the bathroom, they would be transferring on and off the toilet and managing their clothing and doing cleansing. And so it's very possible that the person, let's say, you know, is doing all of those activities, and maybe a helper is providing steadying, touching assistance throughout all of those activities. And so you would code both activities as steadying assistance. Okay, just a coding tip here, toileting hygiene is not considered part of toileting transferring activity, but again, you would be coding those differently, but you'd be thinking about both of them, and it's, again, possible that assistance is being provided at the same instance when both of those are happening. So we do have one example for toilet transfer. So at SOC, Mrs. S is on bed rest due to the new medical, due to a medical complication. She uses a bedpan for bladder and bowel management. The assessing clinician expects the patient will return to independent use of the bathroom toilet once the current condition resolves. So maybe she's got a concern about some medical issue, and so currently on bed rest at this point in time. And how would you code that? So again, the toilet transfer refers to somebody being able to get on and off a toilet or commode. If they don't do that, you would provide a reason why the activity didn't occur. So the options are 02, substantial assistance, 01, dependent, 09, not applicable, or 88, not attempted due to medical condition or safety concerns. Looks like we've got, okay, most people have provided the answer, 88. I do agree with that. In this instance, this patient did not get on and off a toilet, and so the activity did not occur. They did say the goal was that the person would be able to get on and off the toilet. I think it was by herself. How would you code that? Okay, looks like some of the answers are still coming in. Okay. All right, looks like most of you coded 6. That's correct, independent. She was expected to be able to do that by herself by discharge. Okay, and there's the rationale. Okay, I think we'll just do car transfer, and then I think we're ready for our break. So with car transfers, that includes the ability to transfer in and out of a car or van, or on the passenger side. It does not include opening or closing the doors or fastening a seatbelt. So it's really just getting into and out of the car seat, passenger side. It So it, again, doesn't include open and closing doors. If the patient is not able to attempt transfers, for example, because a car is not available or there is weather or other environmental constraints, and the patient's usual status cannot be determined based on the patient or caregiver report, enter code 10, not attempted due to medical, 10, not attempted due to environmental limitations. So again, it could be weather, could be equipment in this scenario, or both. If at the time of the assessment the patient is unable to attempt car transfers and could not perform the car transfers prior to the current illness, exacerbation, or injury, again, 09, not applicable, would be coded. We do have one scenario for this one. So the day after being admitted to home health, Mrs. N works with an occupational therapist on transfers into and out of perpassenger side of car. When reviewing the therapist evaluation, the assessing clinician reads that when performing car transfers, Mrs. N required verbal reminders for safety and contact guard assistance from the OT for guidance and direction. The therapist instructed the patient on strategic hand placement while Mrs. N transitioned to sitting into the car seat. Documentation showed that the therapist opened and closed the door. So again, you can ignore the opening, closing door, but what's important here is it says Mrs. N required verbal reminders for safety and contact guard assistance, so there's touching assistance, and then there was guidance about strategic hand placement. So help is needed. It's more than setup or cleanup, right? And so somebody is providing assistance, and I don't see anywhere in here that it talks about lifting assistance, so it appears that it's just touching, steadying verbal assistance. So I'll let you put in your responses. Options are 05, setup cleanup, 04, supervision touching, 03, setup moderate assistance, 02, substantial maximal assistance. Looks like we have most people coding B04, and I do agree with that. So and here's the rationale. So I think at this point we will be taking a break, and I think Bridget will come up and give us some instructions. Thank you. Okay, great. So we finished off before break talking about car transfers, so we're going to pick up right after that with walking 10 feet. Okay, great. Thank you so much. Okay, so walking 10 feet refers to the ability to walk at least 10 feet in a room, corridor, or similar space. And this activity actually starts after the person's in a standing position. So again, you've already covered transfers, and so in this situation, the assessment of walking 10 feet, which is the first of several walking items, refers to once the person's in a standing position. Coding tip here, use of an assistive device or adaptive equipment, for instance, a cane or a leg brace required to complete the activity should not affect coding of the activity, so it doesn't increase or decrease the score. We do have a coding scenario here for walking 10 feet. Mr. L had bilateral amputations 3 years ago, and prior to his home health admission, he used a wheelchair and did not walk. At SOC, Mr. L does not use prosthetic devices and only uses a wheelchair for mobility. Mr. L's care plan includes assisting with fitting and use of bilateral lower extremity prostheses. The therapist's care plan goal is for Mr. L to walk distances of 30 feet with supervision within the home and then discharge to outpatient therapy. So let's start off talking about his SOC performance. It says he does not use prosthetic devices and only uses a wheelchair for mobility. So in this case, he actually is not walking, and so you'd actually provide a code indicating the reason the activity was not attempted or completed. And then in terms of goal, it says the care plan is that he will walk for distances of 30 feet with supervision. So the supervision, obviously if you were thinking through the decision tree for goal, you would say, okay, yes, there is helper assistance being provided. Is it more than supervision setup? Yes. Is it more than supervision touching assistance? I would say no. It is supervision. There's no lifting assistance or steadying of the trunk involved for the goal. So first of all, we'll be coding the SOC performance. And so if you can pull out your phones, the options are that he is A, dependent, code 1, code 9, not applicable is B, C is 88, not attempted due to medical condition or safety concerns, and 7 is patient refusal. So glad to see nobody coded dependent because he does not perform the activity. And looks like most of you are coding 09, not applicable. The 88 was the other code. The 09 is correct, which is what most of you indicated. And in terms of goal, again, it said that he required supervision, or is expected to provide supervision assistance. And so the options are 06, independent, 05, setup, cleanup assistance, 04, supervision, 3, partial, moderate assistance. Looks like mostly people are coding 4, and I do agree with that code, and so 04 is the correct response. And the rationale, so in this case, the gentleman was not walking prior to the current illness, exacerbation, or injury, and so that's why it's an 09, not an 88. Again, the 88, activity not attempted due to a medical condition or safety concern, would be a new onset, and 9 refers to a illness that has been ongoing, or a condition that's been ongoing. The next activity is walking 50 feet with 2 turns. So this again also starts when the person is in a standing position and refers to walking 50 feet with 2 turns. 2 turns is defined as 90-degree turns. They can be 2 turns in the same direction, or 2 turns in different directions, or one of each. So it could be, again, 2 left turns that are 90 degrees because the person's turning into maybe their kitchen and then making another turn into a dining room. Or it could be that they're making one right turn that's a 90-degree turn and then a left turn that's a 90-degree turn. It should not jeopardize the patient's ability level, that is safety. It can include the use of a device. As for all of the items, a device can be used during the assessment, and so it could in this instance include walker or crutches or some kind of leg brace without affecting the code. So we have a scenario here. So at SOC, Mr. B is recovering from a recent stroke and now has difficulty walking. So he's got a recent onset condition. Even with assistance, he is able to walk only 30 feet. So the item that we're working on is 50 feet with 2 turns. Mr. B's care plan includes muscle strengthening and gait training. The therapist expects Mr. B will be able to walk 50 feet with 2 turns safely with the assistance of a caregiver for verbal cues and contact guard for steadying assistance on the turns. And that's at the point of discharge. So thinking about his current status, so the item here is walking 50 feet with 2 turns. He's not able to walk that distance. And for walking, because if a person is not able to walk the full distance, a helper can't help the person walk the rest of the distance, basically. Probably they're going to be using a wheelchair or scooter or some other mode to get around. And so if the distance cannot be walked, you would code one of the activity not attempted codes. And so in this instance, you'd have to think about why the person couldn't perform the activity, and it's a recent stroke. So then in terms of the care planning, certainly it's reasonable to expect that he will be able to walk 50 feet with 2 turns. And it says that the assistance that's expected for the goal, the level of assistance is expected to be verbal cues and contact guard. So he's not going to be independent. He's not going to be able to perform it by himself. Is it more than setup? Yes. The next level down on the decision tree was that supervision assistance, which included being there and providing instructions, verbal cueing, or contact guard. Okay, so the options to code performance. So again, he had a recent stroke and is only able to walk 30 feet, and we're coding 50 feet. So would you code him 02, substantial maximal assistance, 1, dependent, 9, not applicable, or 88, not attempted due to medical condition or safety concern? Looks like we've got about 85 people who have answered, and it looks like most people are coding 88. I do agree with that. So here's the right answer, 88. And then in terms of goal, so it said supervision and some verbal cueing is the expected level at the time of discharge. Response options are 06, independent, 05, setup or cleanup assistance, 04, supervision touching assistance, 04, partial moderate assistance. Looks like we've got about 105 people who have answered so far. Okay, most people did code 04. I agree that would be a reasonable discharge goal based on what's been described. Okay, and here's the rationale that, again, he's ambulatory but not able to walk the entire distance because of his new condition. So if somebody's not able to walk the entire distance for any of the walking items, you'd say the activity was not attempted, completed. The next activity is walking 150 feet. Again, it starts once the person is in a standing position, and it can be in any corridor or similar space if that's possible. Certainly, CMS understands that if the patient's environment does not accommodate walking 50 feet without turns, the person can demonstrate walking with or without assistance 150 feet with turns. And if that can be done without jeopardizing the patient's safety, you can still code the person as independent. So please use your clinical judgment to observe the person walking 150 feet. Okay, so we have an example here, scenario 11, where the person is Mr. R, and he has had a recent endurance limitation due to an exacerbation of heart failure and is only walking about 30 feet before he tires, loses strength, and must sit and rest. He reports he has been walking 150 feet or more with this cane prior to his exacerbation of his heart failure. So at this point, he's not able to perform the activity, and this is, it seems, a recent onset. So how would you code for this particular gentleman? Options are 01, dependent, 09, not applicable, 88, recent medical condition or safety concern, and 07, patient refused. Looks like we've got about 80 people who have submitted, overwhelming 88 of response, and I do agree with that. Great. Okay, and the rationale, as most of you figured out, was that the person had a recent onset condition, does not walk the entire distance. The next activity for walking is actually the last one for walking, and this refers to walking 10 feet on uneven surfaces. So the options are many, but certainly taking somebody outside to walk on turf or gravel is certainly acceptable. The official definition, the ability to walk 10 feet on uneven or sloping surface. It can be indoor or outdoor, and again, turf or gravel or maybe somebody's driveway is an option also. If the patient is not able to attempt walking on an uneven surface, for example, because no uneven surface is available, or there are weather or environmental constraints, so again, you might live in a part of the country where it's either really, really hot and dangerous, or maybe it's very, very cold and dangerous, and so you're not able to assess this. And so the patient's usual status for walking 10 feet on uneven surface cannot be determined, then you could code 10 not attempted to environmental limitations. And as I said before, this is definitely one of the items where we would expect this code to be used more than others. Okay, so we have an example here of walking 10 feet on uneven surfaces, Mrs. N. So we've got a woman here who has degenerative joint disease and is recovering from sepsis. When walking on the uneven driveway, when it was attempted yesterday, Mrs. N came home from the hospital. She reports that her neighbor had to hold her belt and help lift her a little during a few steps. So while she's walking on the driveway, the neighbor also provided help to advance the walker across the gravel driveway as the patient walked. So in this instance, let's walk through the decision tree. So the person's not independent. This is more than setup, cleanup assistance. Is it more than supervision, touching assistance? Yes. So then the next decision needs to be, so there's a helper providing physical assistance. It says that she's holding onto her belt, helping lift her a little bit during some steps. So the helper is definitely doing some lifting assistance. And so then the question becomes, is the helper doing less than half of the effort, which would be a code 3, or is there this lifting assistance with the helper providing more effort than the patient, and that would be a code 2. So I will let you think about that, and I'll just read it again. She reports that her neighbor had to hold her belt and help lift her a little during a few steps. So if you were doing this, you might want to probe her a little bit more, but based on the information, how would you code her? The options, oops, let me just, let's see, yep, the options are 5, setup cleanup assistance, 04, supervision touching assistance, 03, partial moderate assistance, or 02, substantial maximal assistance. Okay, just give people a little bit of time. Looks like we've got about 120 people who have submitted so far. Okay, great. So I would code this in 03. Talked about a little bit of assistance. Perhaps you'd like a little bit more detail. It looks like a few people coded 02. So again, to differentiate 03, the patient is performing more than half the effort. Level 2, the helper is performing more than half of the effort. Okay, next we're moving on to the steps items. And so here, one step is the ability to go up and down a curb and or one step. And I do want to highlight a skip pattern here. So in order to reduce burden, if on the sock rock performance, it is coded 07, 09, 10, or 88, so the person cannot go up and down one step. We expect that the person will not be able to go up and down 4 steps or 12 steps, so you actually get to skip out of those. So if you're assessing somebody on stairs and they can't do it, then you would then skip over to the next activity, which is pick up object. If the person is able to go up and down one step, then obviously you'd be able to code the 4 steps and 12 steps. But just be aware, if you say the person can't go up one step or a curb, then you would you would not be able to enter 4 steps or 12 steps. This applies to the performance only, so certainly even though somebody may not be able to go up and down one step at the start of care, there could be a goal that they're able to do that by discharge. So there's no skip patterns related to goals. That skip pattern only relates to the performance. And since it's about goals, it actually is only sock rock that it applies. Okay, so we do have an example 13 here where Mrs. Z had a stroke and needs to learn how to step up and down one step to enter and exit her home. At the start of care, the physical therapist provides needed verbal cueing as Mrs. Z uses her quad cane to aid her balance in stepping up and back down one step. The therapist does not provide any physical assistance, so it's just verbal cueing. So thinking through the decision tree, the patient does need somebody, so she's not independent. So then is it more than set up cleanup? Yes. So then is it supervision, verbal cueing, or is it more? That's kind of where you should be thinking. So the options for the response are 04, supervision or touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance, or 01, dependent. And I will let you put in your responses there. So verbal cueing was being provided by the helper. Looks like most people are coding 04, and I do agree with that. So got the check mark next to 04 here and the rationale. Okay, moving on to 4 steps. So the ability to go up and down 4 steps with or without a railing. So all of the stairs items relate to with or without railing or any assistive device. If you have a person who uses a wheelchair and they go up and down, you know, either a curb or a step in their wheelchair, or maybe even if they're very skilled, they can go up and down 4 steps. They can be coded on these items. And again, it's going to be based on type and level of assistance. So the device, it doesn't change the score. So as with the prior item, there is a skip pattern here. If somebody cannot go up and down 4 steps, we're going to assume they cannot go up and down 12 steps, and you skip over that item. Coding tip, use of assistive device and adaptive equipment, for example, railing or a cane, required to complete the activity, do not increase or decrease the score. We do have an example here for 4 steps. At start of care, Mr. J, has lower body weakness, and the physical therapist provides light touching assistance when he ascends 4 steps. While descending steps, the physical therapist faces the patient and descends the stairs, providing minimal trunk support with one hand on the patient's hip and the other holding the gait belt as Mr. J holds the stair railing. So we have a bit of a different situation here in that the level, type, and level of assistance going up the stairs and going down the stairs is different, and more assistance is needed to go down the stairs. So in the event that going up and down or getting in or out of bed, so different angles of the activity, so different times that it occurs, there's differences. We did say to take the usual performance in the event that it's happening equally. So in this example, going up, going down, it happens equally. You can take the more dependent episode. So in this particular example, going up the stairs, he needs less help than going down the stairs, so you would code based on the assistance needed to go down the stairs. So just to reiterate that, it says that the physical therapist faces the patient and descends the stairs, providing minimal trunk support and one hand on the patient's hip and the other holding the gait belt. So thinking through the decision tree, so obviously a helper is needed. Is it more than setup, cleanup? Yes. Is it more than just touching, contact guard, verbal? Yes. So then you would code either a 3 or below. So it's your judgment whether the helper is performing less than half of the effort, the patient is doing more than half the effort, so that would be a 3, or if the helper is doing more than the effort, that would be a 2, or if the helper is doing all the activity, that would be a 1. So the coding options here are 5, setup or cleanup assistance, 4, supervision or touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance. Okay, it looks like there's about 100 people who have submitted so far. Okay. Okay, looks like most people are coding 3, and I do agree with that. There is some lifting that's, it's more than touching. Okay, so next is 12 steps. So this is obviously going up and down 12 steps with or without a rail. Coding tip here, if at the time of the assessment the patient is unable to complete the activity due to physician-prescribed restriction, for instance, no stair climbing for 2 weeks, but could perform the activity prior to the current illness, exacerbation, or injury, you can code that in 88. We do have one scenario for you here. So Ms. Y is recovering from a stroke and has had 12 steps with a railing, and she needs to use these stairs to enter and exit her home. The physical therapist uses a gait belt around her trunk and at times is required to support much of the patient's weight as Ms. Y descends and then ascends and descends the 12 steps. So we've got a strong able-bodied therapist here who is helping, let's assume. And so it says that the therapist has a gait belt on and is providing a fair bit of support. So if we talk through the decision tree, obviously helper is needed, more than setup, more than supervision verbal. There is lifting assistance, so if you think the helper is doing less than half of the effort, you would code 3. If you think the helper is doing more than half of the effort, you would code 2. If you think the helper is doing completely all the effort, you would code 1. So this is a little bit trickier, I think, than some of the other ones. The options are to code 5, set up cleanup assistance, or code 4, supervision touching assistance, 3, partial moderate assistance, or level 2, substantial maximal assistance. Looks like most of you are coding level 2. I do agree with that. There was substantial assistance that we were trying to convey in that example. Next is picking up object. So, sorry, I should read the definition. So this one refers to the ability to bend, stoop from a standing position to pick up a small object, such as a spoon from the floor. And so this obviously is related to the person's balance. This does start from a standing position. If somebody is not able to come to a standing position, you would say the activity was not attempted. If at the time of the assessment, the patient is unable to complete the activity and could not stand to perform this activity prior to the current illness, exacerbation, or injury, you would code 09. We do have one scenario here. Mrs. C has recently undergone a hip replacement. At SOC, she walks with the walker without assistance. When she drops a hairbrush from her walker basket, she asks her daughter to locate her long-handled reacher to bring it to her. So she got that from, let's say, her orthopedic unit. They taught her how to use the reacher before she came home. Using the reacher, Mrs. C is able to bend slightly and safely pick up the hairbrush with the reacher without needing additional assistance or verbal cues. So the important part was that her daughter was asked to bring that to her. So thinking through the decision tree, I'll let you do this one on your own. How would you code it? The options are 05, set up cleanup assistance, 04, supervision touching assistance, 03, partial moderate assistance, and 02, substantial maximum assistance. Looks like most of you are coding 05, and I do agree with that. That was set up by the daughter. Okay, now moving on to the wheelchair item. So there's a series of questions at the end that relate to wheelchair. We start off actually with a gateway question. So the question is whether the patient uses a wheelchair and/or scooter. If the answer is no, you're actually going to skip out of all of the remaining wheelchair items because they're not applicable. So if you indicate the answer is no, again, skip. If the answer is yes, then you will continue on with the next item, which is walking 50 feet with 2 turns. So when coding this question, use your clinical judgment to determine if the patient's use of a wheelchair, if somebody does have a wheelchair at home, if the use of the wheelchair is for self-mobilization due to the patient's medical condition or safety concern, if the patient is walking, ambulatory, and does not is not learning to mobilize in a wheelchair and only uses the wheelchair, let's say, for transport when they're going for longer distances, let's say within their assisted living facility or apartment complex, or maybe for community mobility, but is really not using it on a day-to-day basis. It's really just for some occasional community mobility activities. You can code this no, because it's not something that they're relying on for self-mobilization. So the first item, as I said, is walking 50 feet with 2 turns. There's actually 2 wheelchair items. Both of them start with the person sitting in the wheelchair, and it's basically the ability to wheel at least 50 feet and make 2 turns for this particular item. Similar to the walking item, 2 turns refers to 90-degree turns, could be 2 turns in the same direction or a turn in each direction. We have a coding scenario here. So at SOC, Mrs. M is unable to bear weight on her right leg due to a recent fracture. The nurse observes as the certified nursing assistants in the assisted living facility provide steadying assistance when transferring Mrs. M from the bed into her manual wheelchair. Once in the wheelchair, Mrs. M propels herself safely about 60 feet down the hall using her left leg and makes 2 turns without any necessary physical assistance or supervision. So it's really the last bullet that's relevant. So it says that she goes 60 feet, so that's more than the 50 feet. And it says that she propels herself and she makes the 2 turns and she doesn't need any kind of physical assistance or supervision. How would you code her for this particular item? So the options are 06, independent, 05, setup cleanup assistance, 4, supervision or touching assistance, 3, partial moderate assistance. Okay, looks like most of you are coding 06. I do agree with that, and so she got great home care services, so she's independent at discharge, we'll say. Okay. The patient who has been assessed on this particular item, there's a follow-up question asking whether the person used, what type of wheelchair was used. So the options are that the wheelchair was a manual wheelchair or that it was a motorized wheelchair. In the example we just had, she was propelling with her feet, so it was a manual wheelchair. But there is this follow-up question for this wheel 50 feet with 2 turns as well as the 50 feet, because in some instances somebody might travel short distances in one type of wheelchair and longer distances they may use a different type of wheelchair. So the 150 feet talked about. You can assess this using your clinical judgment in terms of you may need to include some turns in there. And so again, concern about patient safety obviously is a primary concern, but you can assess this item by including turns if that's necessary because of the environment. We do have a coding scenario here. Mr. N uses a below-the-knee prosthetic limb. Mr. N has peripheral neuropathy and limited vision due to complications from diabetes. Via observation and patient report, the assessing clinician determines that Mr. N's usual performance is that a helper is needed to provide verbal cues for safety due to vision deficits, and the patient mobilizes his manual wheelchair a distance of 150 feet within his home. So the important thing here is that he needed verbal cues for safety, so that would be the basis of the coding. That would be the type and amount of assistance. So I will let you enter the code. Options are 06, independent, 05, setup cleanup assistance, 4, supervision or touching assistance, 3, partial moderate assistance. Looks like most people are coding level 4. I do agree with that. So yeah, there's a check mark with 4, and the rationale, again, it's just verbal cues. So I want to wrap up talking about the quality measure, and we have about 12 minutes or so. So as I mentioned at the beginning, one of the quality measures that was adopted into the Home Health Quality Reporting Program is this quality measure, which is an application of a measure that is an NQF endorsed measure for long-term care hospitals. So I just wanted to walk through the quality measure and requirements associated with that quality measure. So this is, again, NQF 2631. It is a process measure, so it's basically the fact that as quality care would be documenting somebody's functional assessment, including function in the person's care plan. It is not risk adjusted because there are codes for all types of situations, and so it's really just reporting the code for the items that I'll be describing in just a moment that's really the quality measure, that you are reporting a code describing the patient's status. It has been implemented across the PAC settings to meet the IMPACT Act. Actually, it's already publicly reported for inpatient rehab facilities, skilled nursing facilities, as well as long-term care hospitals just this few months ago. And the quality measure itself reports the percent of episodes, so it's an episode-based measure, with a SOC-ROC and a discharge functional assessment and a treatment goal that addresses function. So an admission assessment included function on admission, at discharge, if the person was not going to an institutional setting, and there was a goal that was included in the care plan as documented by a goal on the OASIS-D. The treatment goal provides evidence of a care plan, and a goal has been established for the patient. For this quality measure, documentation of a goal for one of the functional items reflects that the patient's care plan addresses function. So just to be clear, there is a requirement for this quality measure that at least one self-care or mobility goal is reported. So that's one of the GG0130 or one of the GG0170 activities has a goal. The function goal is recorded at SOC-ROC for at least one of the standardized self-care or mobility function items using the 6-level rating scale. So that's the 01 through 06. At the time of discharge, the self-care or mobility performance is reassessed using the same 6-level rating scale. So in terms of this quality measure, it is actually a percentage value. And I'm going to start with the denominator because that's basically who is included. So it's the number of Medicare, Medicaid, including the Advantage programs, covered episodes of care for patients who are at least 18 years old, and it is obviously during a performance period, so let's say a calendar year. So the numerator is among the people who met the denominator criteria, the number of home health quality episodes with functional assessment data for each self-care or mobility activity, so that's the performance, and at least one self-care or mobility goal. So in order to be in the numerator, so I'm just kind of reinforcing this, what I've previously said. So in order to be in the numerator, there's 3 criteria. 1, a valid numeric score indicating the patient's functional status, or a valid code indicating an activity was not attempted at SOC-ROC. 2, a valid numeric code, which is a discharge goal indicating the person's expected level of independence for at least one self-care or mobility goal, and again, that is on SOC-ROC. And then number 3 criteria is that there's a valid numeric score or an activity not attempted code for each of the discharge assessment items when the person is discharged and not transferred to an institutional setting. So in terms of exclusions, the measure excludes maternity patients, patients who are younger than 18, non-Medicare, Medicaid patients, patients who are not receiving skilled home services. I do want to clarify the discharge, just because this is a little bit tricky. For home health episodes ending in a qualified admission to an inpatient facility, that's a transfer or a death in home, and the discharge functional status, you wouldn't be able to collect that information, so obviously that's not required. We have actually similar situations for the institutional settings where somebody may be transferred on an emergency basis. It's even harder for you to get that information, obviously. For these patients to be included in the numerator, there's actually only 2 criteria. It's really the admission information and the goal, at least one self-care or mobility goal. But if, again, there's an incomplete episode, the discharge data, we understand you're not able to get that information. So the actual items included in this quality measure are the 3 self-care activities: eating, oral hygiene, and toileting hygiene. The mobility items that are included are sit to lying, lying to sit on the side of the bed, sit to stand, chair, bed, chair transfer, toilet transfer, as well as the walking items and the wheelchair items. In the event that you indicate that, I'll start with walking, in the case that you indicate on the form that the person is not able to walk 10 feet, then basically you are skipped over the 50 feet with 2 turns and 50 feet, but the fact that you answered the 10 feet, you're providing the information about walking, so you're fine there. And then in the event that somebody does not use a wheelchair, if you answer the gateway question saying the person does not use a wheelchair, then you get skipped out of all the wheelchair items, and so you've provided the correct, the needed information for wheelchair because the person doesn't use a wheelchair. So just the gateway basically is enough on that one. So in summary, we covered a lot of content, so I really appreciate all your attention and your engagement in completing the scenarios together. So section GG assesses the need for assistance with self-care and mobility activities. It was added to OASIS-D to support the cross-setting quality measures work in relation to the Impact Act. Section G items are different from the M items, and GGO 170 and GGO 170 are kind of the key items in this area, and you have the option to use the 6th level rating scale or the activity not attempted codes. On the SOC ROC, you'll see performance and discharge. On the discharge assessment, you'll see just performance. I think we're running out of time to do the share your action plan, so I apologize for that. But Bridget's going to come up here and help us transition to the next presentation. I believe you will be getting a survey on your, okay, Bridget's covering it for you. Thank you so much.